All right, well, good morning, everybody. Thank you for being here. My name is Kevin Brennan. I'm the Communications Officer for the Cuyahoga County Board of Health, and this morning we are here for the unveiling of Cuyahoga County's first county-wide Community Health Improvement Plan. And to help us introduce the plan will be the co-chairs of HIP-Cuyahoga, Greg Brown, who's the Executive Director of Policy Bridge, and Dr. Heidi Gullett, Assistant Professor at Case Western Reserve University School of Medicine. So please welcome Greg Brown.
As Kevin said, my name is Greg Brown, and I am the Executive Director of Policy Bridge. Policy Bridge is a research and advocacy think tank that focuses on public policy issues affecting African American and other underserved communities. I am also, as Kevin said, one of HIP-C's co-chairs, and it is my profound pleasure this morning to first welcome you and also thank you for coming. The Health Improvement Partnership Cuyahoga is a diverse and committed group of more than 100 people and organizations. Is to provide a brief overview of the first ever countywide health improvement plan created by HIP-Cuyahoga and to also address any questions you might have. The Community Health Improvement Plan is the culmination of several years of research, community engagement, planning, and shared decision-making. With this launch today, we transition to meaningful action. The Community Health Improvement Plan, or CHIP as we call it, is a guide for our community for addressing some of the most pressing issues impacting the health of our community. HIP-Cuyahoga is important to me because it offers the county an opportunity to understand how our values, our history, our governmental and organizational systems, our policies and our practices have a direct effect on the health and other social and economic issues that serve as barriers to racial and ethnic minorities reaching their maximum potential to be healthy and live happy and productive lives. Thank you. And at this time, I'd like to bring up our co-chair, Dr. Heidi Gullett.
Thank you, Greg. I really appreciate the opportunity to work alongside you and so many others in the HIP-Cuyahoga consortium. We are very pleased today to unveil the first ever countywide Community Health Improvement Plan, also known as the CHIP. This really gives us an opportunity to display the last several years of work where we have intentionally focused on engaging our community and our neighbors to find out what priorities really matter in our community, and then also to think about ways to actively address them. We have intentionally focused on not only community engagement, but also something called health and equity in all policy. That's very important because that's different than other plans you may have seen in the past, as we're very focused on also changing the way structures impact the health of our community. We often focus on specific priorities like high blood pressure and asthma, which we continue to focus on in this plan. But we're also very focused on those larger structural issues like poverty and racism that can be very difficult to address in a concrete way. So we hope that you will enjoy hearing a little bit more from others involved in this plan about the specific priority areas as we entertain some of your questions. Our priority areas include examining and dismantling the barriers created by structural racism in our community that lead to disparities, which we have seen for a long period of time here. We're also interested in looking at how we improve chronic disease and how we increase opportunities for healthy eating and active living. Finally, our fourth priority area is an increase in collaboration between both healthcare, clinical care organizations, and public health. These four priority areas are the culmination of the last few years of community engagement and research in understanding what matters to our community. And this today is a call to action as we move forward in really moving the needle on these four issues. We are also joined this morning for some question and answer with the other co-chairs of the committees that I mentioned, Dr. Erica Trappel from the Prevention Research Center for Healthy Neighborhoods, and Rita Horwitz from Better Health Partnership. Dr. Trappel is leading the Healthy Eating Active Living Subcommittee, and Rita is leading the Chronic Disease Subcommittee with a focus on high blood pressure. So I'd like to invite them up to take your questions. Thank you. So a hallmark of what I just discussed was that we were engaging with our community on a number of levels to understand what matters to them. And so a really important part of that is, now that we're moving into action, how can community members get involved? This is an open consortium. We really want folks to be a part of this, to have their voice heard as we move forward. And so we have a website, as well as subcommittee meetings that are open and can be attended by anybody who's interested, and we would love to have additional community members involved. Our communications officer will provide you with the specifics about how to get involved if you're interested. We really try to engage a wide sector of the community with regard to understanding what mattered to them, and we do know that we have a lot of high quality healthcare institutions, and so many people living with chronic disease may choose to live close to those organizations because transportation is a problem. So we understand that that's an issue, but we also know, when we look at our data, that some of the biggest disparities that we see in outcomes for chronic disease and things like life expectancy are also concentrated closer into the city. So while some folks may choose to live closer to the hospitals where they need to get care, we also know that a lot of folks who live there don't have the kind of outcomes we would hope. And so our goal is that we would reduce some of the barriers that lead to health issues with health for all of our county, but particularly in areas where there is higher need.
We know that 1 in 4 residents in Cuyahoga County live in a food desert, and that number goes up to actually 1 in 2 in the city of Cleveland. And so what we're really looking at is strategies to improve healthy food access, which will make a real sweeping change through implementations of some of the things we're looking at. So we're looking at healthy retail, so really engaging stores and retail locations in offering healthier options, and doing that work in collaboration with residents, getting resident input into how stores could change things that they offer in order to better serve those residents. We're also looking at ways to increase opportunities for physical activity. We talk about built environment and the safety of streets and sidewalks. And so one of our strategies for our Healthy Eating and Active Living subcommittee is actually increasing adoption of complete and green streets, so that as we continue to develop, we're also developing roadways that allow for safe biking and safe walking. Sure, that's a great question. A lot of those partners are partners of the HIP-Cuyahoga consortium, the Greater Cleveland Food Bank, and the Hunger Network of Greater Cleveland. And so those partners are part of the consortium and actively talk about ways that they can have an impact. There are already a number of programs that both organizations run that bring local produce and fresh produce into their food pantries to increase healthy options. And I think now through the consortium, we're looking at a more coordinated and strategic way to ensure that there are healthy options throughout the city and county.
Cardiovascular disease is still the leading cause of death in the United States. We know that 1 in 3 Americans has high blood pressure, and that significantly contributes to the cardiovascular disease that we see in the incidence of that, the prevalence of that. And we know that just about everybody is touched by that in some way, and that it creates economic burdens. There's a big price to pay for that. And so we are attacking it from all directions. We know we can't necessarily eliminate chronic disease, but we can work from all directions to help reduce the incidence of it. And that is the reason why we're starting to look at not just the clinical care that we deliver to address high blood pressure, but connecting it to the social determinants of health as well. We know that where people and their living conditions and their working conditions affect how well they can manage their blood pressure. And we've seen disparities in blood pressure control between whites, Hispanics, and African Americans. So we're bringing in best practices that we've learned from Kaiser, actually, that was published in JAMA in 2013, where they improved blood pressure control amongst all populations from 44% to 80% good blood pressure control. We're leveraging that work. We're bringing it to Northeast Ohio. We're putting it in clinics and working with providers to learn what that is so that we can reduce that disparity.
I think the issue of eliminating structural racism is one that is cross-cutting with all the other priorities that are identified in the CHIP, and that is because what we've learned most recently is that social and economic conditions have a great impact on the health of individuals living in communities. So you cannot just think about health care as a tool to solve health problems. You have to think about it in a more global sense. And when we think about those barriers, challenges through our past practices historically and policies that were created that have transitioned through the years and are still evidenced in many communities today, we see that people have obstacles in their way to employment, access to high-quality health care, good education, environmental conditions may not necessarily be great where they live, and those things impact not only the individual's quality of health, but also their mentality and their psychology, which creates stress. And toxic stress can be seen in many ways through high blood pressure and other areas. So getting to the issue of structural racism through our organizations and our structures and systems through government and other entities is a priority for us. It is one that has to be addressed. It is one that has to be considered, and we will not see changes in disparities and inequities until we address those structural and institutional racism issues that have evolved over time.
So that's an excellent question, and one which our epidemiologist for Cuyahoga County, Chris Kippis, and his staff have worked very carefully to help us understand better. There are very specific areas where disparities are very marked in our county, and they contribute to the overall life expectancy. When you understand life expectancy, it is a measure of the overall health of a certain community or population. And so here we know that there is a problem with infant mortality. Babies are dying before their first birthday, and they're dying here more often than elsewhere. But our African American babies are dying even more often than their counterparts who are white. So while cardiovascular disease is a major contributor to death in this community, so are these other issues, which are directly impacted by things like structural racism and policies of the past. So we're working very specifically with Rita and her group to improve things like high blood pressure, which contribute to that life expectancy disparity that we see. But we're at the same time addressing other specific issues like infant mortality and cancer, because those are also disproportionately high and contributors of death in this community as well. The issues of poverty and racism are inextricably linked, meaning they're very closely tied together. And if you look at the maps of poverty in this community, and you look at the maps of infant mortality, and you look at the maps of life expectancy, they're very similar. And they're also very similar to the maps that indicate prior policies such as redlining in this community. And so we understand that those policies created structural reasons for why our community is not healthy, but those are very clearly linked to poverty. And so we know those rates of death of those particular conditions are higher in communities living in poverty. And those communities are also concentrated closer in to the city as opposed to further out in our county. With regard to HIP-Cuyahoga, we don't include those specific data points in this plan, but they have gone into the overall understanding of what makes this community healthy, and also understanding that the disproportionate death rate from cancer in our community here in Cleveland. But we do have those data, and we do know that there are clearly environmental influences not only on cancer, but also on other chronic conditions like asthma and chronic obstructive pulmonary disease, or COPD. So while I can't specifically tell you where those clusters are, we know that the environmental conditions in our community clearly link to cancer, asthma, respiratory control, and all of those are related to other sort of structural barriers that make it really difficult for certain groups of people in our community to be healthy. Within HIP-Cuyahoga, that specific issue is not in our work plan. However, we have a very robust air quality, public health program in the Cleveland Department of Public Health in collaboration with Cuyahoga County Board of Health, and we also do cancer cluster investigations within public health. So those are very important components of what we call surveillance, which is how we understand who is sick and why they're sick and where they live and what triggers might be impacting those outcomes. So that's not a specific part of this actual plan, but it is part of the larger picture, and the people who do that work are part of this consortium. There are multiple data sources that went into preparing this plan and understanding what priorities are the most important. Some of those are numbers or quantitative, and those include everyone in the county. And our Division of Epidemiology looks at vital statistics, at Census Bureau data, at data from the Ohio Department of Health. And that's not specific to an individual community. They understand where people from those communities live because of zip code and census data. But there was also a primary data collection, meaning we actually went out and collected surveys from many thousands of people in the community to understand also qualitatively what priorities mattered to them. And so we tried to disproportionately get folks who were affected in the communities that had higher life expectancy disparities. We tried to get those surveys increasingly from those particular areas of our county to make sure they were represented, because they often are not represented in systematic reviews of the county. But what's important is that if you look at the quantitative or the number data, that includes the entire county, and we have maps that help us understand where folks are located physically and how that is related to race and ethnicity and levels of poverty in the particular place where they live. Because as we know, place matters. Your zip code can determine more of your life expectancy than your genetic code, and so it's really important for us to understand where those folks are living and also compare them to folks living elsewhere. So there are a lot of variables in it, but we've really tried to account for all of them.
So that's actually part of the work that we'll be doing in the coming year. You're absolutely right. The food must be affordable in order for people to want to be able to buy it, and part of that issue is solved by creating a distribution model that allows us to get healthier foods into those stores. That is part of the work that we'll be doing as part of our HIP-Cuyahoga plan, is looking at distribution models that work within the structures of those small stores that allow them to buy at a lower price so that they can still have a profit margin, but still not have the sale price be so high that it becomes, again, inaccessible for the folks who live on the ground.
Sure, so it's a great question, and the question is, how exactly are you going to coordinate between clinical care and public health? We know historically that clinical care organizations and public health organizations do great work, but they often do great work in isolation or separated from one another. And what we know is that community health problems and the reasons our communities are healthy or unhealthy are related more to structural issues or big issues in the community than they are to very specific or smaller issues around the care that someone receives in an office visit. So while that's really important, and as a physician, that's what I do, that's my regular job, is seeing patients in the office. So for me, that's really important. I can't do that separated from what public health organizations do, which is address these bigger issues like racism and poverty and air quality and environmental conditions. So we know that those have to be linked, they have to work together. But historically, they've been so separated that we had to be very careful about why are we doing this and how are we going to get it done? So we've taken two approaches. One is we're showing on the ground a demonstration project where we've linked an environmental health watch, which is a community organization, and the Cuyahoga County Board of Health, who do environmental inspections of homes where there are conditions that lead to poor asthma. We've used that program and linked that to a clear plan in the medical system. So the doctors are ordering home visits that are being conducted by public health, and then changes in that home are happening that then improve the conditions of asthma for those children. So that's one specific example that we're demonstrating the partnership on the ground in a very concrete way. But the second piece of this is that we in public health in this HIP-Cuyahoga consortium did a community health assessment that you're hearing about today that led to this plan. But hospitals also do community health assessments. They're called community health needs assessments. And they've often been done separated or in isolation. And so our other goal in this particular part of the plan is to bring those together, that hospital systems and public health organizations would together design, and then implement their community health plan assessments so that the next plan, the next CHIP that you are here to hear us talk about, the data have been collected together, the plans have been generated together, and so together we can move forward with shared priorities for our community and potentially have a much bigger impact.